Next, we are going to focus on the clinical pharmacology of the antipsychotic drugs. And in general, as we work through this section, I will be comparing and contrasting the first generation antipsychotics from the second generation antipsychotics in terms of their therapeutic effects as well as their side effects. Let's start by reviewing the effects on symptoms and side effects of the first generation antipsychotics. Again, the first generation antipsychotics are potent D2 receptor antagonists. This affects symptoms of psychosis by reducing the positive symptoms of schizophrenia, such as hallucinations and delusions. This dopamine D2 antagonist activity has little to no effect on the negative cognitive or mood symptoms of schizophrenia. The side effects of the first generation and second generation antipsychotics can be divided into two categories: whether they are side effects related to the on target activity at the D2 receptor or side effects related to off target activity not associated with the dopamine D2 receptor. For first generation antipsychotics, their D2 related side effects include extrapyramidal side effects, or EPSEs, hyperprolactinemia, as well as an antiemetic effect. I will discuss these side effects in greater detail in a moment, but for now, just know that the risk of these dopamine D2 related side effects is directly correlated to the D2 receptor affinity, with stronger affinity drugs having more side effects than lower affinity drugs. The off-target side effects of the first generation antipsychotics include the side effects related to activity at alpha-1 adrenergic, muscarinic, and histaminic receptors, QTC prolongation, and also a syndrome known as neuroleptic malignant syndrome. Again, I will talk more about these side effects momentarily. In comparison, the second generation antipsychotics with their dopamine D2 and serotonin 5-HT2A antagonist activity are able to reduce both the positive and the negative symptoms of schizophrenia. They may also have an effect on the mood symptoms. However, in general, neither class of antipsychotics has an effect on the cognitive symptoms. The D2 related side effects of the second generation drugs are actually the same given their dopamine D2 antagonist activity. These are EPSEs, hyperprolactinemia, and antiemetic effects. However, given the typically lower D2 affinity for the second generation antipsychotics, these D2 related side effects are typically lower or less serious in the second generation drugs. In terms of off target effects, second generation antipsychotics are well known for their ability to produce metabolic syndrome, as well as QTC prolongation. Again, I will talk more about the metabolic syndrome side effect momentarily. Let's now discuss some of the side effects of the antipsychotic drugs. And first, we will start with the extrapyramidal side effects. These are called extrapyramidal because they are occurring outside of the pyramidal region or section of the brain. And in general, these effects are all due to decreasing dopamine activity in the nigrostriatal pathway. Dopamine signaling in the nigrostriatal pathway is very important for the control of voluntary movement. And decreasing dopamine signaling in this brain region is associated with the extrapyramidal side effects listed here. These include acute dystonia, akathisia, drug-induced Parkinsonism, and tardive dyskinesia. Acute dystonia is characterized by painful muscle contractions of the jaw, tongue, and upper trunk. This is a nigrostriatal pathway effect. Akathisia is a movement side effect associated with a compelling inner restlessness and a need to be in constant motion. This is actually The one exclusion to the nigrostriatal hypothesis, as akathisia is thought to be caused by dopamine activity in the mesocortical pathway. Drug-induced Parkinsonism is the ability of antipsychotic drugs to produce a condition that very closely mimics Parkinson's disease, including the characteristic motor symptoms of tremor, rigidity, bradykinesia or slow movement, and a shuffling gait. Again, this is due to activity in the nigrostriatal pathway. Tardive dyskinesia is involuntary movement of the tongue, lips, jaw, facial muscles, and is potentially an irreversible effect of antipsychotics. This is also due to activity in the nigrostriatal pathway. These side effects will be covered in some greater detail in the therapeutics section of this course. The risk of extrapyramidal side effects is directly correlated with the dopamine D2 receptor affinity. Drugs with very high D2 receptor affinity, like haloperidol, are known for producing significant extrapyramidal side effects. Whereas drugs on the other end of the spectrum, such as clozapine, which have relatively low D2 affinity, are much less likely to produce EPSEs as a side effect. In summary, drugs with affinities below the blue line are more likely to produce extrapyramidal side effects than drugs with affinities above the blue line. Another side effect that is mediated by dopamine D2 antagonism is hyperprolactinemia. This is due to blockade of dopamine D2 receptors in the tuberoinfundibular pathway. This results in increased prolactin levels, which can cause various physiologic effects in humans, including menstrual disturbances, galactorrhea, sexual side effects, and also decreased bone mineral density that can predispose to the development of osteoporosis. Galactorrhea is spontaneous release of milk from the milk ducts in the breast tissue. In general, hyperprolactinemia is more common with the first generation antipsychotics than the second generation drugs. And this again is because the first generation agents have much stronger affinity for the dopamine D2 receptor. These drugs also have antiemetic effects, and this is due to dopamine D2 receptor antagonism in the chemoreceptor trigger zone in the brainstem. Again, first generation agents are more likely to have this side effect than second generation drugs. Possible off target effects for antipsychotic drugs include orthostatic hypotension due to alpha 1 adrenergic antagonism, antimuscarinic effects, including drying mucous membranes, flushing, redness, and urinary retention due to inhibition of the muscarinic M1 receptor, and antihistamine effects, including sedation and weight gain due to inhibition of the histamine H1 receptor. Antipsychotic drugs may also prolong the QT interval. Unfortunately, there is no simple rank of risk for the drugs, and this is simply a factor that must be known about each individual antipsychotic in terms of its risk for prolonging the QTC interval. The risk of a problematic QTC prolongation is increased when individuals taking antipsychotics have a history of heart disease, a family history of heart disease, congenital long QT syndrome, or take other drugs that also prolong the QT interval. The easiest way to remember drugs that do and do not prolong the QT interval is to memorize the drugs that do not prolong the QTC interval. Specifically, aripiprazole, fluphenazine, and chlorpromazine do not prolong the QT interval. Most other antipsychotics do have this effect. All off-target effects shown on this slide may be present in any of the first or second generation antipsychotics, depending on their affinity for the various off-target receptors. One of the most prominent side effects of the second generation antipsychotics specifically is what is known as metabolic syndrome. This is the triad of diabetes, weight gain, and dyslipidemia. In terms of weight gain, approximately 50% of first episode psychosis patients gain weight on a second generation antipsychotic. The average weight gain is on the order of 4 to 7 kilograms, or somewhere between 8 and 15 pounds. Weight gain is easier to prevent than it is to reverse, and so appropriate measures should be instituted whenever an antipsychotic associated with this weight gain is administered. In terms of the dyslipidemia and the hyperglycemia or diabetes, this is evidenced as an increase in fasting triglycerides, increase in LDL cholesterol, as well as an increase in blood glucose. It is important to screen and monitor for changes in these lab values and to prevent or avoid these increases as much as possible. Additional information about metabolic syndrome will be discussed during the therapeutics component of this unit. There is a relatively clear delineation between drugs with a high risk of metabolic syndrome and those with a low risk. In general, the second generation antipsychotics have a much higher risk of metabolic syndrome than do the first generation antipsychotics, as evidenced on this graphic. The drugs that are undesirable because they have a higher risk include clozapine and olanzapine, whereas in the other extreme, drugs that are more desirable because they have a lower risk include haloperidol and fluphenazine. There is not a direct one-to-one relationship in terms of metabolic risk between first and second generation antipsychotics, but it is a good general feature to remember that the second generation drugs are more likely to produce this effect. The last potential side effect of any antipsychotic drug is a condition known as neuroleptic malignant syndrome. This is a very rare but potentially fatal side effect of antipsychotic drugs, as it is associated with 10 to 20% mortality when it does occur. It is characterized by severe Parkinsonism with catatonia, autonomic dysfunction, and stupor. The autonomic dysfunction typically manifests as a fever, very high fever, and unstable blood pressure. When neuroleptic malignant syndrome occurs, it can persist even after the offending drug is discontinued. It is much more common for this to occur with high doses of very potent drugs like haloperidol, especially if those drugs are given parenterally. Here is a diagrammatic summary of the side effects with regard to first generation and second generation antipsychotics. Those on the left are related to the effects of first generation antipsychotics primarily, where you can see the side effects of most concern are the extrapyramidal side effects, including tardive dyskinesia. On the other hand, of greater concern for current antipsychotics, which are primarily the second generation antipsychotics, include the metabolic syndrome characterized by diabetes, dyslipidemia, and weight gain. The extrapyramidal side effects and tardive dyskinesia have become slightly less concerning with the use of the newer generation antipsychotic drugs, but are still present and should not be ignored. When considering oral dosing of the antipsychotic drugs, most of them in general have very similar pharmacokinetics. Most of the antipsychotics are relatively lipophilic, and they are either membrane or protein bound in the bloodstream, which can result in them having large apparent volumes of distribution. They accumulate in fatty tissues, including the brain and the lung, and they do cross the placenta and enter breast milk. Most antipsychotics have relatively short half-lives, but with the existence of active metabolites, their biologic effects typically persist for at least 24 hours, which permits once daily dosing. In addition, the antipsychotic drugs have slow elimination kinetics, and therefore there is usually a delay in the changes to symptoms after drug discontinuation. Antipsychotic drugs undergo extensive CYP P450 metabolism followed by phase 2 conjugation. And therefore, whenever an antipsychotic drug is added to a regimen, it is important to verify and evaluate for potential P450 interactions. At this point is a good time to stop and complete the antipsychotics pharmacology optional assignment in Canvas, which will review the ability of the various antipsychotic drugs to produce the side effects that we discussed. Take a pic of the QR code on the screen to access the assignment directly.